Is it working now? Great. Okay. Good afternoon, everyone. I'll be talking today about diffuse alveolar hemorrhage. I want to thank Dr. Baraja for helping me in preparing this presentation. This presentation has no conflict of interest or any off-label promotion of medications. I'm going to start with defining diffuse alveolar hemorrhage, talking about etiologies as well as how to diagnose it, specific entities associated with DAH, overall treatment, and what happens to those patients on the long run. First of all, diffuse alveolar hemorrhage it could be one of three entities. It could be secondary to bland pulmonary hemorrhage, diffuse alveolar damage, and pulmonary capillaritis. And most of my talk today is going to be about pulmonary capillaritis. The reason behind that is because it's the most common entity. And what I'll be talking about today is small vessel vasculitis. So it's going to include the ANCA-Associated disease as well as the immune complex diseases. Now, what's pulmonary vasculitis? It's the inflammation of lung vessels of any size. On the other hand, capillaritis is inflammation that's confined to the microcirculation of the lung, and that includes the alveolar capillaries, arterioles, and the venules. And it's seen in both systemic vasculitides as well as in connective tissue diseases. Now, on pathology, there is neutrophilic predominance, fibrillar necrosis of the alveolar and the capillary walls, as well as leukocytoclasis. So what happens is that the neutrophils squeeze between the capillary basement membrane. The nuclear debris of those neutrophils accumulate within the interstitium, and this leads to the loss of the integrity of the alveolar capillary basement membrane, thus the accumulations of RBCs in the alveolar spaces. Now, once we talk about etiology, it could be either part of a systemic disorder or it could be localized to the lung. And if it was part of the systemic disorder, that means it could be either vasculitis or connective tissue disease. Localized to the lung could be either as part of inhalation injury or diffuse alveolar damage. And those are the causes for DAH, and they're broken down by the type, pulmonary capillaritis, bland pulmonary hemorrhage, as well as diffuse alveolar damage. So as I said, pulmonary capillaritis is the most common cause for diffuse alveolar hemorrhage, and it happens in 88% of the cases. This is a pie chart showing the percentage of the patients who have DAH who end up being admitted to the intensive care unit, with P-ANCA vasculitis being the highest percentage of those patients. Hematopoietic stem cell transplant, those are a small percentage, but it's important to, this population is really important to recognize too. Occurs in 5% of around 4,000 patients. So a little bit about physiology. There's increased binding of the carbon monoxide, there's increase in diffusion capacity, and the reason behind that is because there's increase in the intraalveolar hemoglobin. However, that resolves after 48 to 72 hours, and that is because the hemoglobin is broken down into hemosiderin. And with alveolar hemorrhage, what happens is there's going to be VQ mismatches, and that would lead to worsening respiratory failure, often requiring ventilator support because of respiratory failure. So there's two important things to think about once you're thinking about diffuse alveolar hemorrhage. First of all is you need to make the diagnosis. The second thing is you need to identify what's causing diffuse alveolar hemorrhage. What's the underlying cause? Now, so how do patients present? Around 70% of the patients present with hemoptysis. It's usually a dramatic event, happens very quickly, devolves over days to weeks. Patients could present with fever, chest pain, cough, as well as dyspnea. It's very important to do a physical exam on those patients, not just looking at the X-ray and calling crackles of an X-ray. You need to do an upper airway, as well as you need to evaluate for GI bleedings as sources as bleeding sources. You also need to look closely into the eyes. That's to look for episcleritis or retinal vasculitis. Look into the nasal pharynx, looking for nasal septal erosions, as well as saddle nose deformities, and examining the skin, looking for leukocytoclastic vasculitis. So those patients, they present, they're anemic, and they have a drop in their hemoglobin like 0.5 grams per deciliter per day. They have chest X-ray findings that I'll be talking a little bit about later, as well as as well as chest CT scan and ground glass opacities that confirm X-ray findings. Bronchoscopy is important in this population and it's required for the diagnosis, as well as it's important in order to rule out infection. And surgical lung biopsy, and that is only if serological testing or the clinical history is not revealing. So why is bronchoscopy important? That's because series of BALs shows worsening hemorrhage, and that is diagnostic of diffuse alveolar hemorrhage. I'll be talking a little bit about this score, but so this score is a gold score. It's a cumbersome scoring system, and it's not used, but it's nice to know a little bit about it. What it does is that it assesses the hemosiderin content inside the macrophages. So what they do is that they examine 200 macrophages, and they score the hemosiderin content based on what they see in the macrophages. For example, if there was no color, then the macrophage takes a score of 0. On the other hand, if there was like a deep blue throughout the cell, then the macrophages will take a number of 4. And what they do is that they divide the score by half, and that is in order to get the hemosiderin score for a mean of 100 alveolar macrophages. And if the gold score was more than 100, then that means that the patient has severe DAH. On the other hand, if it was between 20 to 100, that means that the patient has mild to moderate DAH. This is cumbersome. Just more than 20% hemosiderin-laden macrophages are enough to say are enough to call a diagnosis of diffuse alveolar hemorrhage. Not only that, but BAL is important. That is in order to rule out infection, acute HP, acute eosinophilic pneumonia, as well as PAP. So, what do we see on imaging? This was a study that was published in 2008. Dr. Cortez et al. What it is that they did a retrospective study, and they wanted to describe chest X-ray as well as CT findings of DAH. So they retrospectively reviewed 23 episodes of DAH in 20 patients. 17 of them had known etiologies for the DAH, 3 did not have any known etiologies. And so they studied all the cases by chest X-ray, and 15 of them by CAT scan too. Consolidations and ground glass opacities were evaluated, and the lung was divided into 3 zones each. So there was 3 regions each. So there was a total of 6 zones. And what they concluded was the following: DAH is radiologically characterized by a non-specific alveolar filling pattern. Diagnosis or suspicion of DAH needs to be supported by the evidence of hemoptysis and/or rapid onset anemia. CAT scan is superior in detecting ground glass opacities, and is required in cases of suspected DAH but with normal chest X-ray findings. So it's the non-specific alveolar filling pattern that you see on the on imaging mainly. So what you can see also is curly B lines, and you're going to need to think also about PVOD and mitral stenosis. If you see nodules, as well as cavities, you need to think about Wegener's as well as RA. Patchy alveolar opacities. And those are cuts of CT scans of patients. Those are high-res CT scans, more sensitive to look for DAH. What you see is ground glass opacity as well as consolidations, and also ground glass opacities, and peribronchiovascular inflammation, and ground glass opacities too, all of which suggestive of DAH. How about labs? So once you get those labs, patients, what does leukocytosis mean? It doesn't mean anything. It could be secondary to any cause. On the other hand, thrombocytopenia, you need to start thinking about cytotoxic drugs, antiphospholipid syndrome, lupus. Increased sed rate could be secondary to any cause too. If you have urine red blood cell cast, you need to start thinking about pulmonary renal syndromes, any systemic vasculitis, lupus, mixed connective tissue disease, Goodpasture syndrome. Abnormal coags, you need to think of drugs, coagulation disorders, as well as lupus. How about specific labs? ANA means patient has an underlying connective tissue disease. RF means patient also has either an underlying connective tissue disease or an ANCA-Associated Granulomatous vasculitis. C-ANCA patients, you start thinking of ANCA-Associated Granulomatous vasculitis and microscopic polyangiitis. And P-ANCA, microscopic polyangiitis, as well as ANCA-Associated Granulomatous vasculitis. So those are the specific labs that you need to order in order to evaluate for the underlying cause of DAH. So for the diagnosis of DAH, BAL is enough. But you need to also look and evaluate for the underlying cause of DAH, and this is more of what you could get out of from a clinical standpoint. Clinical history is important, and serological findings. And you only send for a surgical lung biopsy if there was isolated DAH, but there was no obvious cause. When would you do a renal biopsy is that when the serological findings are equivocal and you're thinking of vasculitis in the back of your head as well as Goodpasture syndrome. Now what do you see on pathology? You see interstitial erythrocytes and/or hemosiderin. You could see fibrinoid necrosis of capillary walls, intraalveolar septal capillary occlusion by fibrin thrombi, neutrophils and nuclear dust in the interstitium and the fibrin and the adjacent alveolar spaces, and fibrin clots attached to intraalveolar septa in a sessile manner. So it's could see so those arrows are pointing to neutrophils. You could see also so there is an increase in the amount of RBCs also in the alveoli, and this goes more with chronic DAH picture where you could see the macrophages and the hemosiderin, the bluish color in them. Now, to my other part of the talk is talking about specific disorders that are associated with diffuse alveolar hemorrhage. I'm going to start with isolated pulse-immune pulmonary capillaritis. This is a small vessel vasculitis. It involves the lung. You have no clinical or serological features, and it's the most common of DAH, carries a good prognosis. The other entity, that's idiopathic pulmonary hemosiderosis. On the other hand, this is a rare syndrome. Patients have repeated episodes of DAH. They present with chronic anemia, and they have pulmonary fibrosis. Usually, patients are less than 30 years of age, and it's more and the incidence in the pediatric population is 0.24 in 1 million. And if you biopsy them, you're not going to find evidence of capillaritis, and what you're going to see is alveolar basement membranes that are thickened and intact. You'll see hemosiderin-laden macrophages because it's a chronic process with recurrent episodes of DAH, and lungs would have a brown color. That's because of the abundance of hemosiderin. There's varying degrees of fibrosis as well as consolidation. It's an immune process, thus it responds to immunosuppressive therapy, and it's distinct in histology from other causes of DAH, from capillaritis. Now, ANCA-associated granulomatous vasculitis, and this is a big percentage of the patients that end up in our ICU. It occurs more in men as well as the elderly. It's a systemic necrotizing vasculitis. There is granulomatous inflammation of both the upper and the lower respiratory tract. ANCA-positive antibodies directed against cytoplasmic PR3, and the expression of PR3 on the surface of neutrophils means that those patients are at increased risk of higher rates of relapse. C-ANCA has a higher sensitivity and specificity, and it's suggestive of either presence of the active disease or relapse. I'll be talking a little bit about treatment here, but later I'll be talking more on the broader picture regarding treatment for most of DAH. So treatment will include induction as well as maintenance, and the induction of remission in this population is through corticosteroids and cyclophosphomides, and for maintenance therapy could use methotrexate as well as or azathioprine. And there is a role of rituximab. It's mainly in those patients who have refractory vasculitis. And the role of plasma exchange is useful if thought of and instituted early in the disease course. Now, MPA, microscopic polyangiitis, it's a systemic vasculitis, focus segmental necrotizing glomerulonephritis. There's no upper airway involvement, and around 30% of the patients present with DAH. MPO ANCA titers are checked, but they're not associated with disease activity. And a lung biopsy is usually not necessary because P-ANCA, if it's positive, it's suggestive. The regimen for induction of remission, steroids, cyclophosphamide, as well as plasmapheresis. There is a role of recombinant factor 7A that I'll be talking a little bit more about later, especially in patients who have severe DAH and MPA with unremitting respiratory failure. And how this works is through the enhancement of thrombin generation on the surface of activated platelets at the site of hemorrhage. SLE, so 4% of the patients suffer from or could present with diffuse alveolar hemorrhage, and it's secondary to pulmonary capillaritis. It's important to rule out pneumonia in this patient because near all of them are immunosuppressed. 80% of the cases there's kidney involvement, and it's usually in the young females. Has a high mortality if you don't treat them, 50% without treatment. And it's important. So those both entities could overlap, and by overlap I mean you couldn't distinguish initially. That's because they have similar clinical radiographic features as well as systemic symptoms, and you need the BAL in order to differentiate. On histology, the appearance of lupus pneumonitis would be diffuse alveolar damage, organizing pneumonia, and nonspecific cellular pneumonitis. Treatment for both entities is the same, DH or ALP. You start with high-dose pulse steroids. And if they were steroid resistant, the best combination would be adding cyclophosphamide. Could also use azathioprine and IVIG. And there's a questionable role of plasmapheresis, mainly in patients who have mainly refractory cases. There has been no survival benefit. I'm going to be talking about plasma exchange in a while. Other connective tissue diseases. So the other ones, those are infrequent, but they could happen. So mixed connective tissue disease, RA, polymyositis, dermatomyositis, primary antiphospholipid syndrome, and scleroderma. I'll be talking a little bit more about antiphospholipid syndrome too. So DAH may be the presenting manifestation, or it could complicate a pre-existing disease, and treatment is similar to the treatment of SLE. DAH. Goodpasture syndrome, or anti-GBM antibody disease. Those are antibodies that are against the NC1 domain of the alpha-3 chain of the basement membrane, collagen type 4. They involve the lungs as well as the kidneys, and smoking has a role here. On histology, what you're going to see is bland hemorrhage. You could also see pulmonary capillaritis. It affects young men, and there's circulating antibodies in 90% of the cases. So what smoking does is that it leads to the damage to the alveolar basement membrane, and this would lead to the generation of the autoantibodies. Could present without renal involvement. It's similar to isolated pulmonary capillaritis if that happens. And if patients have negative antibodies, biopsy is needed. It's either lung or renal. And what you're going to see is you're going to need immunofluorescence, and that's in order to see the linear antibody deposition within the alveolar or the glomerular basement membrane. And this helps in establishing the diagnosis. So to treat those patients, immunosuppression and plasma exchange. There is a role for rituximab here, and it's mainly in patients who are refractory to therapy. How does rituximab work is through two ways. It reduces the production of the antibodies, and it reduces the cellular interaction. Why is that important? Because reduction of the cellular interaction leads to decrease in the production of the cytokines, as well as decreased production of the immune complex formations. plasma exchange, as you know why. Lung allograft rejection. It's a necrotizing post-inflammatory septal capillary injury. You need tissue biopsy over here in order to differentiate between the acute cellular rejection versus post-transplant capillaritis. Treatment is apheresis and IV steroids too. Now, bone marrow transplant, I know it happens in a small percentage of patients, but once patients who have bone marrow transplant with DAH, that means this should be a red flag. It's the cause of death in 60% of the cases, and it happens more in the autologous. Mortality rate could reach up ranges from 50 to 100%, and those risk factors increase the mortality rate, old age, total body radiation, myeloablative conditioning regimens, as well as severe acute GVHD. Hemoptysis occurs in around 15% of the cases, and what protective strategies in order to help prevent this entity is the reduction in the intensity of the conditioning regimen. Why it happens, it's unclear. It could be secondary to tissue injury, it could be secondary to underlying inflammation, as well as cytokine release may have a role there. On biopsy, what you see is DAD, diffuse alveolar damage, or you could see pulmonary capillaritis. And treatment is supportive with mechanical ventilation as well as steroids, but there's questionable effectiveness there too. Now, interesting thing about primary antiphospholipid antibody syndrome, I always thought it was just a thrombotic disease, but patients also come with diffuse alveolar hemorrhage, and this is within the pulmonary findings of antiphospholipid antibody syndrome. And how does that happen is through the following mechanism. So what happens is that those antibodies, the antiphospholipid antibodies, bind to the receptors that are on the capillary endothelial cell, and this leads to the neutrophil to go to migrate and through the capillary to the alveolar capillary endothelial membrane, and this will trigger the whole process, where the nuclear debris is going to cause inflammation and then destruction, and then RBCs are going to pass through. They respond quickly to steroids. Disease recurrence is common. So there is a role here for long-term management and so you need to suppress those patients for a long time. Those are the meds that are used: Celsep, azathioprine, cyclosporin, IVIG, and rituximab. There is a role of plasmapheresis here. It's mainly in the acute setting, and there's questionable benefit if you use HMG-CoA reductase inhibitors and hydroxychloroquine. So those are the main causes for DAH. But as I was saying before, is that we need to do a BAL, we need to rule out infection. And why is that the case? Because it should be also included within the differential of diffuse alveolar hemorrhage, and this could happen in immunocompetent hosts too. Early targeted therapy in combination with supportive treatment and possibly steroids will improve survival in this patient. And the most frequent causes of infections are H1N1, dengue, leptospirosis, malaria, Staph aureus, hantavirus, CMV, and TB. So what about treatment? I was talking a little bit about the treatment earlier, but the overall treatment is going to be the following. It's broken down into two phases. The first one, first of all, you need to control the active disease. So it's the remission induction phase. And the second treatment is the maintenance phase, and you need to prevent relapse of the disease. And this would include less intensive therapy and helps in maintaining disease remission. IV steroids, high dose, up to 500 milligrams every 6 hours for 4 or 5 days with a gradual taper. And then the decision regarding add-on of immunosuppressive agent depends on the severity of the illness, what is the underlying cause of which disease causing the DAH, and how are patients responding to steroids. And in severe cases that are refractory to steroids, you should start thinking of cyclophosphamide, azathioprine, methotrexate, Celsep, and etanercept. Apheresis, especially in Goodpasture syndromes, as well as there's data behind for other vasculitic processes. So you need to have high titers of immunoglobulins as well as immunocomplexes for apheresis to work. This is what I'm going to say about plasmapheresis. It's enough. So what's the role of plasmapheresis in non-GBM? There is data for use of plasmapheresis in Goodpasture syndrome or anti-GBM disease. This study was published in 2003 in American Journal of Kidney Disease. It's a retrospective study. What they did is that they wanted to assess the role of apheresis in patients who have DH associated with with ANCA small vessel vasculitis. It was a retrospective study done over 6 years, and they looked into apheresis and induction immunosuppressive therapy. That included IV steroids and or IV cyclophosphamide. And they had what this study shows is impressive results, but it's a retrospective study. I just want you guys to keep that in mind, is that DH resolved with apheresis in 100% of the patients. There was no complications of therapy, and half of the patients who came in with azotemia were discharged with improved renal function. So what they concluded was the following. ANCA-related small vessel vasculitis and DH benefit from prompt initiation of apheresis coupled with aggressive immunosuppressive therapy. And such therapy can be life-saving with respect to the pulmonary component of the syndrome. So there is a possible role of apheresis in Wegener's MPA. You should do it in patients who have Goodpastures and Lupus. And so this is a table. This is a grading system. It's called the European Vasculitis grading system. And how do they grade DAH? Is based on end organ involvement, constitutional symptoms, renal function, threatened vital organ function. And this population here is mainly what we end up seeing in the unit. And as you see here, in severe cases, there is a recommendation for use of plasmapheresis. Refractory, they say consider investigational agents. Plasmapheresis should be one of them, too. No.
You see that reaction is greater than 500. We're talking here about non-anti-GBM. So we're talking about anti-induced vasculitis. So the Lupus trial randomized patients to either high-dose steroids plus cyclophosphamide and oral methadone versus no high-dose steroids. No high-dose steroids, but again, baseline immunosuppression. So plasmapheresis plus cyclophosphamide. Okay, so they compare it to pulse steroids plus cyclophosphamide. And if you look here, the group that really got benefit of pheresis was mainly patients who came to you already with high creatinine greater than 5.7, okay, or with dialysis dependent. So forget about the diffuse alveolar hemorrhage. If you're not telling me that there's no diffuse alveolar hemorrhage, nephrology might come tell you creatinine is not greater than 5.7. I'm not going to do pheresis. The current data does not support using pheresis in patients with a creatinine less than 5.7 or who are not dialysis dependent. And to confuse you more, this is exactly the opposite of what we do for anti-GBM disease. In anti-GBM disease, if the creatinine is greater than 5.7, it means your kidneys are closed, there's no role of pheresis. If it's less than 5.7, it's pheresis. Okay? So what happens in general in real life, the patient is having in the ICU, she's having diffuse alveolar hemorrhage and she's ruled out infection. It's most likely one of those two. So you start pheresis from your end, So the kidney function is irrelevant if you think that this is either ANCA or anti-GBM. Make sense? So, but if there is, or you're confused about the diffuse alveolar hemorrhage, nephrology is probably going to approach it based on data.
if you get a patient that you don't know what his background is,
if I rule out infection,
then you,
this is my approach. This is not science. So, so if I see somebody with diffuse alveolar hemorrhage, no, I'm serious. With diffuse alveolar hemorrhage, I don't think he has the pneumonia. I'm asking for those. I release them with the expectation that this patient, even if they're genuine, so that this might be anti-TBM. And then I suppose, but most of the time by the time I put the death for the anti-TBM.
Okay, and then just going back to DAH alone, because I think fusion medicine gets worried and maybe we're looking into like, oh, this doesn't have any data to support its use in recovery of DAH. And that's based on looking at 6-month data for long-term recovery in these patients. Without immunosuppression, those patients will relapse. So you can use plasma cases. It's mostly based on case reports of not even refractory, but just using plasma cases and in refractory cases of DAH. So it can have a role, but they will always ask, okay, what is your immunosuppression plan? What are you doing for that? Because without that, you have a very high rate
you need
of
to
relapse.
control the disease and take out the antibodies. See? I lost my hand. So the second phase in treatment is maintenance therapy. So you need to maintain control of the disease. Here you usually use less immunosuppression. Again, azathioprine, methotrexate, CellCept, leflunomide, and cyclosporin. And immunosuppression could go up to 18 months, even longer, if the patient is at high risk for relapse. So what's the role of factor 7A? And this was a study that was published in Lung in 2015. It's a retrospective study. It was a retrospective chart review done over 10 years, around 10 years. What they included is what they included was 9 ANCA vasculitis, 2 SLE, 3 Goodpasture syndrome, 7 post-bone marrow transplant, 1 ITP, and 1 cryoglobulinemia. 22 of the patients were in the ICU, and 18 of them were intubated. And how they did is that they gave factor 7A every 2 hours until hemostasis was achieved. Around 36% of the patients died, but there was no adverse thrombotic events observed with the use of factor 7A. Something to think about. So what they concluded is that activated factor 7A can achieve homeostasis in patients with DAH. So they were like hard to control. Something available and also think about. Is there a role of ECMO in those patients? Yeah.
Sorry, are you saying that means they didn't use anything else?
No, they used the immunosuppressive regimen. They used immunosuppressive agents, but those patients had severe DAH that they had to also use also had to use add-on therapy, and it was factor 7 refractory.
Your understanding of the study is that in 10 years they had 24 patients with DAH, and that was only a subset of all of their patients with DAH? It sounds to me like they're saying that every patient they had with DAH they just put on factor 7.
They looked into the patients that they put on factor 7. It was retrospective, and they saw what the benefit of factor 7 was on those patients.
They didn't have criteria under which they used factor 7?
And by criteria, I mean what I'll need to look into that. I understood what your the question is, did they die because of how severe their disease was? Obviously, their disease was severe for them to use factor 7A. So that's how I interpreted that around a third of them ended up dying. If you have refractory cases that already are on immunosuppression, you're releasing them. I mean, something to.
That's what I'm sure of. That's your understanding. Is they
Yeah.
released all these patients, they gave all immunosuppression, and they still weren't bleeding. When did you do it?
What's that? You'd go to this here. So this is a retrospective review. I mean, you need prospective data to say this is 100% working, or this is like the drug of choice to add on. But I mean, if you have a refractory case and I mean DH was like out of control, what are you gonna do? I mean, it's gonna be I mean, it means you're having like worsening hypoxemia, you're not being able to manage them on the vent, I mean, you're gonna think of ECMO. Those steps, I mean, you're gonna like throw everything on the on patients. Is there a role for ECMO in those patients? There is some data in the pediatric population, and this paper was published in 2015 too in Heart, Lung, and Vessels. This was published in the United Kingdom. But what they did, so they reviewed 2 cases that they did ECMO on. Those were young patients in their early 20s, and those were patients that had severe DH to the limit that they can no longer, they were very hypoxic and they weren't able to control them on the mechanical ventilator. And the rationale that they had behind the use of ECMO was they wanted to give some time for the immunosuppression to kick in. That's why they did ECMO, and both patients did well. One was after 2 days, is when they considered ECMO. The other one after 12 days. So more experimental drugs. If you go to UpToDate, you're going to read about aminocaproic acid. There are 2 studies on aminocaproic acid. Both were retrospective. Both were on bone marrow transplant. One showed benefit. This other study did not show any benefit for this drug. Now, are there any predictors for worse outcomes? So this, I'm going to talk a little bit about this also. This study that was published in 2015 in arthritis rheumatology. The purpose of the study is that they wanted to look into patients who had DH secondary to ANCA-Associated vasculitis, and they wanted to identify predictors of respiratory failure. They wanted to look into the efficacy of plasma exchange, as well as, which is better, rituximab versus cyclophosphamide in patients with or without respiratory failure. It was a single-center cohort study over a 16-year period. They did logistic regression models in order to examine the predictive role of the baseline clinical characteristics for the development of respiratory failure. They did also logistic regression models for the role of plasmapheresis and induction of remission therapy on the main outcome, looking at complete remission at 6 months. Those were the following results. So the degree of hypoxemia upon initial presentation, higher neutrophil percentage in the BAL counts, and higher CRP levels, those were independently associated with the development of respiratory failure. Plasmapheresis was not associated with achieving complete remission at 6 months, and rituximab was found to be better than cyclophosphamide in achieving complete remission at 6 months. Something important to know is that they just did, there was bias once it came to also plasmapheresis, that they just did plasmapheresis on those very sick patients. I think that played a role in having those results. So the most important predictor for respiratory failure is how much hypoxic those patients were on admission. The benefit of plasmapheresis added to standard remission induction therapy could not be demonstrated in this study. And patients with DH secondary to ANCA-associated vasculitis, including those requiring ventilation, achieved complete remission by 6 months at a higher rate with rituximab than with cyclophosphamide. I'm going to also talk about this study that was published in 2010 in Journal of Critical Care. The aim of the study was to characterize patients and to report the outcome of DAH requiring ICU supports. This was also a chart review. They looked into 37 patients. 89% of those patients came with shortness of breath. 23% of them had cough, and only 3% of them had hemoptysis. In 9% of them, the diagnosis of DH was suspected on admission, and the diagnosis was confirmed in this patient by progressive hemorrhagic BAL as well as positive iron stain. Those were the underlying causes for diffuse alveolar hemorrhage in those patients. And what they concluded was the following: DH should be considered in everyone. In all patients who have persistent pulmonary infiltrates, BAL and iron stays are mandatory for the diagnosis. And the main reason I'm talking about the study is for those two outcomes, that immunologic pathogenic mechanisms offer a good, usually have a better prognosis than patients who have the age secondary to cancer therapy or sepsis. So what if there was lung involvement? Patients who have vasculitis, what if they had lung involvement? What does that mean? And this is what this study talks about. This study was published in Immunology in 2014. It's titled Lung Involvement at Presentation Predicts Disease Activity and Permanent Organ Damage at 6, 12, and 24 months, follow-up in ANCA-Associated Vasculitis. And what they concluded in this study is that patients who come with vasculitis and there is lung involvement, they had a more serious and a more worse disease, and that is also looking down the road at 6, 12, and 24 months. And then introduction of immunosuppressive therapy has helped a lot in improving the survival of those patients. So just to summarize my talk on this great algorithm. So if we get up for at night and we get this patient who has hemoptysis, have chest X-ray findings of alveolar infiltrates, he has anemia, it's very important to dig a little bit more and take history. That would include not only history but also physical exam. So if there was an offending drug, you need to stop the drug, of course. If on physical exam, there was a loud murmur heard, bedside echo would help in evaluating the mitral valve to rule out mitral valve prolapse or mitral valve regurg. If the patient had a history of lung and bone marrow transplant, you need to start thinking of rejection, as well as you need to start thinking of DH associated with bone marrow transplant. You also need to do the physical exam and start considering ordering blood work as specific blood work, ANA, sed rates, GBM, antiphospholipid antibodies, and BAL eventually in order to diagnose DAH as well as to rule out infection. And treatment usually start with high-dose steroids and call for apheresis and go from there. I think that might be a good start. And I'd be more than happy to answer any question.